I'd like to welcome Shashi Hirani. Shashi is a lecturer in the Division of Health Services Research and Management here at City University. He has a wide range of interest in health service research, including the use of assistive technology in health and social care, patient and carer cognitive representation of their illnesses and treatments, carer support, and the design, development, delivery and evaluation of self-management interventions in chronic health conditions. He was involved in the Whole Systems Demonstrator project, about which he's going to talk to us today.
I'm going to talk today about a little bit about the work that our team's been doing in the field of teleassistive devices and how it's becoming an increasingly important area in health and social care service provision. Although I'm delivering this message, I'm delivering it on behalf of a tremendous team who've done a lot of work on this project, and this is only a small amount of that work. So there's lots of people involved in this work that I'd like to thank as well. Okay. Today I'm going to discuss about the current and potential roles that technology may have in the way that therapists and researchers approach the management of long-term conditions and the increasing global burden of ageing, where people are having more illnesses and becoming more frail, therefore requiring more health and social care services. Okay. So I'm going to present a topology for assistive technology, give an overview of the WSD project, focusing down on the patient-reported outcomes within the project, and going to talk a little about the lessons and challenges that we found while doing the WSD on how we should deliver teleassistive devices. Okay. I know that you all realise that technology moves at a tremendous rate. You'll be surprised to hear it's been 50 years since we got to the moon with the power of a graphical calculator. So the processing power to get to the moon was just a graphical calculator, and today it's been 40 years since the first mobile phone. And today we carry devices around in our pockets that have got magnitudes more power than what it takes to get to the moon. Furthermore, these devices are interconnected that you can talk from here to someone on the other side of the world in real time. So there have been great technological advances. Just to sort of put that into context, Twitter's only been around for 6 years, iPhones since 2009 and iPads in 2010. And now most people have these things and they're part of everyday life. So technology is advancing at a really great rate. And I'm going to say medicine and healthcare haven't been unaware of this, and they've tried to utilise. They've got a vision for how technology can help their service provisions. Okay, so they've quickly realised the potential of these devices, and they're looking to. They have a vision where there'll be homes that are fully interconnected, have sensors around the house. They'll monitor you as you go in. Anything happens, they'll send off an alert. They think they can provide services from remote, so experts in the field can be easily accessed via devices, and they'll wheel themselves into the ward and give you a consultation. You can deliver services over the internet. We've got a project going on currently whereby we're delivering speech and language therapists. They've got iPads. And then there's the mobility of devices. These little things you carry in our pockets are all multifunctional and can do many different things, including monitoring bodily functions. Okay, so there's a great vision out there, and the key is to remotely collect diagnostic information. Okay, the fact is that there's been so much work that there's a whole plethora of terms that have been developed to describe this work. There's telehealth, teleassisted devices, telecare, telemonitoring, telepractice, telerehabilitation, telemedicine, teleconsultations. And this whole mishmash of words that are used in different ways. So as part of the WSD, we sort of try to form a topology for these different types of technology. And the key aspect is that they are providing remote delivery of services and the remote exchange of information. Okay. So and we've come up with 3 different terms: telehealth, telecare, and telemedicine, which all sort of are based on the functions and what they're asking the patients and services to do. So for telecare, we think this is a more passive monitoring, which hopefully reduces technophobia, because people don't actually have to do anything with the technology, and the devices are placed in their homes. They don't actually have to interact with it. So it's very much passive monitoring, and this occurs synchronously. So monitoring occurs 24/7, and these devices are placed in the house. So you have your house either built with these devices or retrofitted with sensors which look at your functioning. So it could be fall detectors, pull cords, bed occupancy or chair occupancy sensors. It could be security, so movement sensors, door exit sensors, etc. It could be environmental, so heat, cold, flooding, or they could be standalone push button, big button phones, or memo mind, there's motion lights. And these things are all connected to a central base box, which is wired up to a central station, which is monitored. And you monitor 24/7. A sensor triggers, so for instance, if you fall, you've got a fall sensor on your hip, you fall down, a trigger will sense, the sensor will send a signal up to a call centre who will try and contact you and say, Mr. Jones, are you okay? And based on your response, they might either call a carer, the emergency service, or a GP service to come and deal with the situation. Okay. In contrast, telehealth does require activity from the service user, and these people either have to take measures, react to measures, or place devices, put the devices on themselves, or wear the devices. And actually, monitoring can be synchronous, so 24/7, constantly monitoring, or it can be asynchronous. They can store the information and forward it to you. There can be a whole range of devices that I use. They can be for blood tests. Diabetics might have blood tests. Heart failure patients might have sensor for weight scales. There might be pulse oximetry. There's a whole range of sensors that can be used depending on your own individual needs. The measurements that you're required to take are either directly sent through a set-top box to the call centres, or they're stored and forwarded. And on the other side, there'll be an algorithm monitoring these measurements and reacting on whether you've missed measurements, whether you've gone out of range, or whether there's any unusual patterns of readings. And then on the basis of this, there'll be a red, amber, green system whereby there'll be an alert, and the operator, who may be a healthcare professional or just a call centre worker, will decide whether you should wait and see what happens. So just do nothing at the moment. Contact the patient themselves, contact the GP, contact your hospital consultant, or contact A&E to get someone out to you straight away. So there's a whole step to response depending on what the reading is saying and your response to the readings. And finally, there's telemedicine. This is more about remote consultation. So a consultant may work in conjunction with a nurse to do a diagnosis from a distant hospital, rather than travelling down to the local hospital. They may do it from a central hospital. They may have pre-prepared packages of therapy which are delivered over the internet, and they monitor your progress and intervene as required. Or it may be real-time therapy, whereby they use Skype or FaceTime or some televideo conferencing technology to deliver a consultation directly to you. At the most extreme, we've got new devices whereby surgeons are conducting surgery remotely using robotics. So the scope of telemedicine is quite large. Okay. Given there's a whole new range of technology, and there's so many things happening, the envisaged benefits are quite large. We believe that these will help enable both telehealth, telecare, and telemedicine. Will enable patients to remain independent and in their homes, so they can be in the community for longer and hopefully improve their quality of life and reduce social isolation. We hope that it will help save time and money on travelling, so for a professional to travel to you or for you to travel to the professional. We also hope that there'll be an opportunity for early identification of problems, or timely identification of problems, whereby we can reduce complications and reduce unnecessary hospitalisations. Also, this technology provides a whole vast and improved access to specialist knowledge. It can facilitate team-based care and multidisciplinary teams if the information is shared across the whole team. Furthermore, the kit may provide reassurance and support such that there'll be carers around, there'll be someone there for you to talk to, and hopefully reduce anxiety and depression levels. And finally, we hope that all these little things put together can drive down costs of providing care. We know that the world is ageing. We know that there's going to be greater demand. Many more resources are going to be required. So if these things can force down the cost of care and healthcare, it would be really advantageous to our society. The vision is compelling. It feels that there's so much that can be done and should be done. However, and there's lots of positivity around this, and there'll be lots of people having a great drive to introduce such technology into the world, into the healthcare and the social care services. However, the evidence of the benefits is, despite a steady growth over 20 years, the evidence base is less firm. And in particular, these will be patient-reported outcomes, but these do apply across the board to the research currently done. Although there's increasing research, quite a lot of it has been qualitative, so we can't accurately quantify the impact of the case of this equipment. Further, a lot of the studies have been small end, so we can't really generalise their format. Often the follow-up periods have been quite short, and there's been a question about the quality of this work, and they don't tend to meet orthodox standards for doing large-scale research. And if the component research that you put into a systematic review is of poor quality, what you produce out of it is also going to be of poor quality. So there's a concern that what we're finding from systematic reviews may not be representative. And in fact, what we're finding is that in systematic reviews, you're pooling poor studies and you're pooling various outcomes that don't necessarily match together. The quality of life is being pooled with medication adherence. So it's a garbage in, garbage out sort of approach to research if we look at some systematic reviews at the moment. So at the moment, we're at the balancing point. We don't actually know whether these great advances in technology are going to benefit us in the way that's envisaged. So in response to this, the Department of Health commissioned the Whole Systems Demonstrator project, and it had the aim to provide a comprehensive evaluation of the addition of Telecare and Telehealth to whole system design. So the Whole Systems Demonstrator focuses on Telecare, Telehealth, and not so much on telemedicine. The plan was to assess 6,000 individuals and up to 660 carers with a variety of methods and different levels of analysis. So it was a very ambitious project which was aiming to address some of the failures of past research by doing a large-scale, large-end, multi-method project. The evaluation itself was multi-centred, and it was based across three sites, Kent, New and Cornwall, which have varying populations. So you can see Cornwall will be slightly elderly, more white population. New is more multicultural, possibly more deprived here, and Kent lies somewhere in between. And it covered 4 PCTs across these three areas. Okay, the broad aim was to find the effectiveness of telecare for patients with social care needs, so passive monitoring patients with social care needs, and for telehealth in patients with long-term care, so active monitoring of patients with conditions. The 3 conditions that was focused upon within the study were diabetes, heart failure, and COPD, which are quite large populations and require quite close monitoring of symptoms and medical indices. So the WSD was one of the largest and highest quality studies to be undertaken in this area. It was a pragmatic cluster randomised trial, pragmatic because it was a bit of a compromise between methodological, ethical and policy issues. So within the trial we randomised at the GP level using an algorithm which balanced for practice size, deprivation scores, ethnicity, prevalence of long-term conditions and site. And the aim to use the pragmatic clusters was that each GP would receive some form of intervention, so no GP would be left without a tele-assistive device. So Group 1 practices, for their social care patients, they got Telecare, and for long-term patients, they received usual care. And for Group 2 practices, their social care patients got usual care, and their long-term patients received telehealth. So each arm had a form of technology and 1 control group, and effectively we had two RCTs running in parallel, a comparison of Telecare and usual care, and a comparison of telehealth and usual care. Okay. Telehealth participants were identified from the GP databases using QOF data and codes within the system. They had to have a confirmed diagnosis of diabetes, COPD or heart failure. They required the home to have a telephone line, and in Newham they required a television set. And they needed sufficient English skills to be able to use the kit itself, but often there would be prompts from the system that were in English, or they were asked to respond in certain ways, so they had to have a firm understanding of English. Patients with cognitive impairments were excluded, but patients with multiple comorbidities were included, and with physical impairments were okay as well. Okay. It was the active monitoring system that we described earlier. There were slight differences. Individuals got Newham, Cornwall and Kent had different providers, so sometimes it was Philips, sometimes it was Tunstall, sometimes Veritone. So different service provisions, and the back office service was quite different as well. Newham had a whole package whereby their back office was remote and provided by the kit provider, whereas Kent were doing an in-house system whereby they would receive the call. So the service provision was very different between sites, and in Newham the television set was used, whereas in Kent and Cornwall they used a set-top box that was independent of any kit or any equipment already in the home. But the key commonality was that The focus was on monitoring vital signs, symptoms, and the self-management behaviour. So this was truly active monitoring. In contrast, the Telecare participants were individuals with social care needs identified via databases, a SWIFT database in many of the sites, or lists of services where users had no needs. So if there were fall clinics, they would survey the list and try and recruit from there. And each of the participants must be receiving one type of social care, or whether from this, so it could be night sitting, it could be that risk of falls, or they could have cognitive impairment, or that the carer was having difficulty. Okay, again, they need to have the appropriate power supplies and telephone equipment within the home, and they couldn't have any existing connected telecare. So they might have a pendant, but that couldn't be connected to a central system. And each individual received a needs assessment from the local WSD team and got the appropriate kit for their needs. There were the kit that was used for each of the 3 sites for Telecare was very much similar, provided by one company and one back office. So there fewer differences in service provision in the Telecare arm of the trial. Okay. The WSD evaluation itself consists of 5 themes, asking just slightly different questions. It was, does telehealth and telecare reduce service utilisation? Do these technologies facilitate patient-reported outcomes? So do they increase health-related quality of life or psychological well-being? Is it cost-effective? What experience do patients and professionals have of delivering and receiving this service? And how is the service delivery and organisation impacted? So we're adding a set of services into something that's already there. How is this changing how trusts and service providers change what they do, and how does it impact on their actual organisation? The first 3 sets were quantitative research, and the last 2 were qualitative research. There's a nice mix of methodologies. Service utilisation did look at the 6,000 people, and the patient-reported outcomes and cost-effectiveness were a nested study within that, where questionnaires were filled out by some of the patients of the 6,000 to provide these patient-reported outcomes. We chose some generic but well-known and reliable outcome measures, which covered health-related quality of life, health status, and psychological well-being. So anxiety and depression were also measured simply because we felt that the kits would help reduce anxiety or depression. And there's an additional capability measure using Telecare. Of course, we also collected lots of socio-demographic data and trial-related variables. Measurements were taken prior to recruitment, prior to intervention for the intervention group. So before they got the kit, we didn't measure, and at recruitment, the controls didn't measure. At short term, about 4 months, everyone did a questionnaire, and again at 12 months, another questionnaire. So there's 2 follow-ups, a short term and a long term. At baseline, participants were asked to fill in the questionnaire by themselves, but there was someone there to help them. So should they have any problems filling it out, they had some assistance. At short term, it was mainly postal, and there were follow-up calls and letters to get greater response. And at long term, again, it's initially postal, but if people wanted help to complete it, we contacted them and provided some assistance should they require it. Okay. The telehealth and telecare datasets were treated independently for the analysis. So as there were 2 separate trials, the analyses were done separately for telehealth and telecare. For missing data within any time point, we multiply imputed. And then we conducted linear mixed models analysis on the nested data. So observations were clustered within participants, which were clustered within GP. So the hierarchical nature of the data was represented within the analysis. And we did an intention to treat analysis. So people who were offered the usual care, well, in the usual care one, regardless of maybe by mistake they got teleassistive devices, and those were assigned teleassistive devices were in that group, regardless of whether they got it or not. Overall, the randomisation and actual receipt of kit was fairly good. The covariates we used in each analysis were slightly different, and these just reflect the different context. But in each case, they include the baseline scores of the outcome measure. And separate analyses were done for each of the outcome measures. So there was one analysis for physical health, mental health, etc. The key effects we were looking at were trial arm, time, and the interaction between trial arm and time. And we were looking at the effectiveness of the kit. I'm going to talk about, just to help consume this a bit easier, I'm going to talk about telehealth results separately from the Telecare results. It just helps keep them separate rather than mingle them up. Okay. So in the overall trial, there were 3,230 participants that took part in the service utilisation measures. Of these, about 50% participated in the questionnaire study. And for the intention to treat analyses, we selected patients who completed baseline plus one of the follow-ups. And this was to do with the type of analysis we were undertaking. And that resulted in 1,200 odd patients who completed both baseline plus one follow-up. There were slightly more intervention participants here, and the split in long-term conditions was roughly about what the prevalence rates were. There were many more males than females in the telehealth sample, so long-term conditions seem to be more prevalent in the males. The split across sites, you can see Kent had slightly more. And the majority of participants were what we classify as white, in comparison to non-white. Generally, elderly population, they were averaging around 7. The population was relatively similar between both groups, and they tended to have back to comorbidity. The differences between usual care and intervention were not that great. Obviously, the intervention group got almost 3 pieces of kit, and the odd person got a kit in the usual care arm. Okay, so what did we find? So looking across the measures, so these are the physical health score and mental health score, we found that overall the samples were functioning slightly below average levels, which would be expected in a slightly elderly population. But what's key across all the slides, all the graphs I'm going to show you, is that the scores between the telehealth arm and the usual care arm are very similar. Yeah? If you look at the confidence intervals that are shown there, they don't actually separate. They don't seem to be very different. And again, across time, they don't seem to be very different. This is true across all the outcome measures for telehealth. You can see again in this anxiety, low levels of anxiety, but again, doesn't seem to be too many differences. The same with depression, and the same with the health status score. So what we did find when we applied the intention to treat analysis is that actually not much was happening. There were no trial arm effects, there were no time effects, and there were no interaction between trial arm and time. So it seemed that as it was delivered, telehealth showed no substantive effects. Even the effect sizes were quite small, their confidence intervals crossed 0. Yeah? So it was, we could say that they had no substantive effect, unfortunately. Okay, so the take-home message would be that it's not working, I guess, at the moment. Okay, so then we turn to Telecare. Again, there were 2,600 participants in the overall trial, of which about 45% participated in the questionnaire study. Of these, 873 completed baseline plus a follow-up. So these were the available case cohort that we used for the intention to treat analysis. There's a fair split between intervention and usual care. This time, females were more common. So there were more females who received social care needs. Interestingly, there were about 50% of people were living alone, and the population was slightly older than the telehealth population. Deprivation is slightly higher. And overall, the differences weren't that great between usual care and intervention groups. On average, the intervention group received about 4 devices in their home. So if you think there's a whole large list of devices, but they tended to receive about 4. So although there's potential for lots of devices in these homes, on average only 4 kit, based on their needs. Similar to the telehealth results, the Telecare results show that the functioning of this group is slightly lower than average, and that the differences between trial arm and usual care aren't that large again. So it seems over time they seem to be quite steady for both MCS and PCS, and there don't seem to be too much great differences, although you can see a slightly sneaky one there, maybe. The same was true for EQ5D, so health status and capability scores. The differences don't seem large and don't seem to be changing over time. I find for anxiety and depression, there's slight concern that these are slightly highly depressed group. They're hitting the level for screening, so there might be something of concern there. But again, the difference between trial arm and time aren't that great, apart from possibly anxiety here, which seems to be lower initially and seems to be increasing, but in the whole sample. Okay. Interestingly though, when we ran the analysis and included the covariates, we did find some trial arm effects. So in this case, we found a trial arm effect for mental health and time effects for EQ5E health status and depression. The effect for the mental health component score showed that the Telecare group had a 3-point advantage over the usual care group across the analyses. 3 points seems quite large, however, when we translated this to a effect size, it was 0.18, which is a small effect size relatively. The study itself was powered on a 0.3 effect size, which in itself was small. So what we're finding here is maybe a trial arm effect on mental health, but it's very small, unlikely to be substantive. Furthermore, its confidence intervals were very large and traversed to 0 as well. So there's a possibility of something happening here, but we can't be sure that it's substantive. What's interesting is that this increase in mental health was occurring in the context of a decline in health status. So over time, the EQ5D showed that patients were getting worse in their health status, and they were getting slightly more depressed over the year. So over a year, we actually find significant differences in this elderly population over time. So possibly there's a balance between what's happening with mental health in an overall decline. So there's something there, but we can't make firm conclusions because of the small effect sizes. Okay, so what have we learned? Other than that, we've done a large study that was very high quality, considered to be very high quality, and we found no results. So we didn't see changes in quality of life. So we can't make any substantive claims on any of the outcomes that telehealth or telecare increases quality of life. Okay, but also, conversely, we also didn't find declines in telehealth in quality of life. A few researchers have said that actually introducing kit causes people to focus upon the condition and the illness, therefore it increases anxiety, depression, because they're more living with the condition rather than they're not focusing upon it. But we didn't find that either, so we didn't find a great decrease by trial arm in quality of life. So that's a good thing. So there's a bit of an equipoise there. So we don't know what's quite happening, but it's not good, it's not bad. And if there is an equipoise, is it worth pushing all these resources behind teleassisted devices? Because they're not cheap, and they do involve a lot of systems changes, whereby you have to integrate this whole package into what's existing out there. So we've got to ask the question, is it worth introducing all this new kit as it currently stands? And when I say as it currently stands, we did look at second generation kit, which is peripherals that are added to your usual care with a base box. We're fully aware that there's third and fourth generation devices, both Telecare and Telehealth, being developed, which are more connected. So you've got your automated homes, you've got e-pills which you swallow and it automatically tells you what medication you've done, digestible and wearable monitoring systems that are connected to your mobile phone. All these things are being developed. However, what's currently being offered out there in the real world is Telecare as we describe it and Telehealth as we describe it. And it's unlikely to change because it's going to cost a lot of money to retrofit homes with Telecare, and it's going to cost a lot of money to make it into a smart home, and it's going to cost a lot of money to build smart homes. All these kits cost a lot of money. Mobile phones are very expensive. All the peripherals are very expensive. And to integrate this into our existing systems is going to be very expensive. So, in this current financial climate, where there's very, very little money out there, it's likely that what we have now is what we're going to use for the forthcoming future. Therefore, focusing on the second generation kit is probably correct at this moment in time. It's a bit of a shame that we didn't find any effects. But we could critique that actually you've lumped together three very different conditions, and you should actually look at each one of these separately. Furthermore, you should use more specific measures like health, disease-specific quality of life measures. And not to worry, we are doing that. That's the next step of our analysis. We did include diabetes health profile, living with a heart failure questionnaire, and a CRQ questionnaire for COPD. So we've got disease-specific measures. We've got disease-specific measures of self-care behaviours as well, which we can compare. So we're in the throes of running out these analyses at the moment. So we are looking at whether does it work for individual conditions. We've seen in the health utilisation arm of the trial that I think the COPD showed slight reducing in health utilisation, service utilisation. So there is a possibility of finding long-term condition differences there. Furthermore, we saw in telehealth in particular that the three sites delivered quite different services. Perhaps one service works better than another service. Yeah? So it might be that the package offered by Newer, whereby you use a TV, which in our qualitative work showed that was much more accepted by our users because it was something that was familiar with them. They knew how to use a TV. They could use the remote control to get their graphs up on the TV rather than looking at a small box on the table. So we know that how people accept that kit is different. So it may be that how it's been introduced in the different sites might show that one or two of these different services is more efficacious than the others. So we're looking at side effects on this as well. So this is all work in progress, unfortunately. Furthermore, we also think that we might be able to focus upon in whom would telehealth most work. So we could do individual screening to help to select people for whom telehealth might work the best. Furthermore, we could screen people, and if we find that their beliefs currently don't make them suitable for telehealth, we could perhaps do an intervention to help them alter their beliefs and behaviours to make telehealth more effective for them. So within that, we've developed a screening tool for patients' beliefs about the kit. It's a service user technology and acceptance questionnaire, which is based on 6 dimensions, looking at whether users think the service enhances their care, whether it increases accessibility to care, whether they've got concerns about privacy and discomfort, whether they're concerned about who's looking at the information. So is it a healthcare professional or is it someone in a call centre to get my personal details? Whether they're concerned that the kit is a substitution for usual care, and how satisfied they are with the kit. So we've got a measure that will help us look at the beliefs patients and service users have about the kit they receive.
Where does this measure come from?
We've developed this within the WSD.
From the outcomes, based on the outcomes.
We had a question that was measured at the same time as the other measures were. So this was done after they received the kit. So at 4 months and 12 months, they had an additional questionnaire which asked them about the beliefs about the kit and how their experiences of the kit.
Okay.
And we've done PCA, factor analysis on this to define the different scales, and we're looking at its reliability and validity. And we found that, as it currently stands, actually these scales can differentiate between people who are receiving passive kit and active kit. So people are actively involved, so the telehealth participants see as enhancing their care and increasing the accessibility to services, much more than they are having passive kit. So the beliefs about it do, differ on what type of kit they get. Furthermore, we've been able to use these scales to predict who would reject the kit and those who finished 12 months of the trial. So we found that those who believed it was enhancing the care would continue to use the kit. Those who, for increased accessibility, would continue to use the kit. So some of these beliefs actually state whether they're going to keep the kit, or as we heard, chuck it into the garden, as we found as one participant in the trial. So it's how people think about the kit may influence how they benefit from the kit. So this is a line of work that we're currently developing as well. And finally, we feel that all these services have been introduced. So we've got our technology looking for a solution. So it's been very much technology driven. Manufacturers have made kits and said, look, this is good, do it. But we've not looked, and this is good, it will influence outcome, but we've not looked at what's happening in between. There's a big black box in between, whereby here's kit, here's outcomes. At the moment, we're not making this connection. There's lots of things occurring within that big black box. A lot of them will be patient variables. We'll be looking at self-care behaviours, self-efficacy for self-care behaviours, lots of different sort of individual beliefs. And we think that we've missed a trick here. All these things have been introduced without reference to theory of kit or with reference to theory of behaviour change. So if we can meld together these techniques with the kit, perhaps if the aim is to self-manage patients properly, we should use our past existing knowledge to help deliver the kit and get better outcomes. So there's a big black box. There's lots of work to be done. We're looking at some of it, and obviously there's lots more to happen. But I think at the moment we're in a bit of an impasse where we've only connected 2 variables and we're looking at the mediating moderating variables. Okay. That's all I've got to say. I'm sure our team is quite happy to field questions on this as well. And I'd like to thank all the participants, the DH, the 3 sites, and the team from the city, and all our colleagues from other universities who have contributed towards the WSD project.
Thank you very much.